I thought we'd talk today about 4 questions, and I asked you to think about what would be your answers to each of them. How is it possible that the American healthcare system costs almost twice as much as any other nation, and yet when we look at clinical outcomes, according to the Commonwealth Fund, we are last amongst the 12 most industrialized nations? You know, how is it possible that every other industry, the introduction of computers, data analytics, robotics, AI has raised quality and lowered cost, and in healthcare, costs have gone up and quality has stayed stagnant? How is it possible that physicians who earn $300,000 a year and have the privilege to take care of patients have a 44% burnout rate and 400 physician suicides a year? And maybe most importantly, what can we do about it? And how will direct primary care lead the way? So let's start with this first question. The American healthcare system is broken. It most closely resembles a 19th century cottage industry. I mean, it's fragmented. Doctors scattered across the community, unconnected with each other. It's paid on a piecemeal basis. The more you do, the more you get paid. It doesn't matter whether you improve outcomes. The technology we use is left over from the last century. No, it's actually left over from the century before that, because the most common way that doctors exchange vital patient information is the fax machine, an 1834 invention. Right? And if change were to happen, who's going to lead it? There's no one in healthcare with that ability to be able to make medicine better for patients. And the outcomes are what you would expect. The United States spends almost $13,000 a year per person every year. Switzerland's about $10,000, Germany's $8,000. Everyone else is half of what we spend. As I said, the Commonwealth Fund found that we are last amongst the 12 industrialized nations. And I don't mean in minor kind of ways. We're talking about life expectancy, 5 years behind almost every other country. We're talking about childhood mortality. We're the worst amongst the 12 nations. And maternal mortality? Your chances of dying are 4 times higher giving birth in the United States than these other 12 nations, unless you happen to be a black woman. And then it's 10 times higher. But it's more than just these systemic issues. And I realized that in December of 2019. The United States government published data that predicted healthcare costs would go up 5 to 6% a year every year for the next decade. That would mean that by the year 2030, we would be spending $2.5 trillion more per year for healthcare. And I'm not talking about better healthcare, it's the same healthcare. And I expected some of the organizations that we all belong to would step forward and say, this is absurd. Imagine if we use this money for social determinants of health. How about racial disparities in healthcare? What about chronic disease? What about just education for preschoolers? Could we spend $2.5 trillion more better each year? And I waited, and no one stepped forward. And I realized that there's also this culture of medicine. And the culture of American medicine says we're the best. What we do is excellent, and if you want to keep getting this great care, you should just simply pay us for it. The idea that it could get better doesn't exist. That denial, despite all the evidence that's published, denial about the problems is intrinsic in the culture of medicine, and the system and the culture intertwine. Like those 2 snakes wrapped around the staff in the caduceus, you know, what a lot of physicians wear and other healthcare providers on the white coats and on textbook covers. The culture of medicine. Culture is the values, the beliefs, the norms that we learn in medical school and residency. And by the way, I'll be speaking mainly about doctors today because that's what I know best. That's what I am. But almost everything I say applies equally well to nurses and PAs and nurse practitioners and a lot of other providers in the healthcare system. The culture of medicine is this values, norms, and beliefs. If you want to understand it better, let me take you back to Austria, 1850. Ignaz Semmelweis has just been appointed the head of the delivery service. He's appalled. Mortality amongst women delivering birth is 18% in his hospital. It's the leading academic center in all of Europe. And he's embarrassed. The facility next door, one run by nurse midwives, 30% lower mortality rate. At the time, the reason women were thought to die was puerperal fever, an infection of the uterus that spreads to the body, killing the pregnant mom. The etiology was thought to be miasmas, smelly particles drifting up in air currents from the streets below. But why? He asked, why should the women in his other hospital not be dying as often as our hospital? They're breathing the same air. Advances in medicine often happen through serendipity. A colleague of Semmelweis's nicks a finger doing an autopsy on a woman who's just died from puerperal fever. He goes on to develop a local infectious systemic disease, and he dies with a clinical course identical to these women who've given birth. Semmelweis hypothesizes maybe there's something these doctors are carrying from the autopsy area to the delivery area on their hands, or maybe those leather aprons they wear to protect their well-pressed three-piece suits. He says everyone will dip their hands in chlorinated water and put on a clean leather apron. Mortality drops in 1 month from 18 to 2%. 90% reduction in mortality. Try to think of something in your clinical history that you've seen improve by 90%. He writes it up in the leading journal. And guess what happens? Nothing. It will be 50 years before Pasteur comes along that doctors change their practice. But why? Why with this strong evidence does nothing change? This is the culture of medicine. You see, in the culture of medicine, it's not about money. It's not about time. It's about respect. And the doctors at the time had massive respect. And the idea that they could be the carriers of disease was not acceptable. And those leather aprons they wore, the more blood, the more pus, the more guts, the better the experience. This was the elevated status. They would no more want to put on a clean apron than the professors at universities would give up their long white coats for the short worn by interns. That is what culture is about. Where you sit in the hierarchy and how do you elevate your status. Fast forward to today. Hospital-acquired infections are the fourth most common cause of death in the United States. 1.7 million people a year get infected, over 100,000 die. The bacterium, everyone in this room knows, you're all clinicians. The bacterium is C. difficile. It doesn't go through the air like coronavirus, it's carried on the hands of people. And yet, studies on both community and academic facilities across the United States have shown time and again, 1 in 3 times, when doctors go from one patient's room to the next, they don't wash their hands. Now, how's that possible? We know it will save lives. This is the culture of medicine. Because in the culture of medicine, doctors see themselves as impossible to carry disease. They are healers. And if they happen to not wash their hands and someone gets an infection, it wasn't them. It had to be someone else doing it. Before I continue to talk about some of the problems with the culture and what needs to happen around it, I want to point out that it's the same culture of denial, that also makes physicians and other clinicians heroes. What do I mean? COVID comes ashore. It's a new virus. We have no ability to prevent severe disease. We have no ability to treat severe disease. People are dying, and doctors and nurses go to the hospital 12 and 24 hours a day. They're taking care of very sick individuals. They're putting themselves at tremendous risk, and they do it anyway. When there's no gowns, they put on garbage bags. When there's no N95 masks, they put on salad lids. They put the patient ahead of themselves. That's the heroic side. When the patient can't breathe, they take breathing tubes, put them through the mouth down to the lungs. They know that as it goes through the vocal, What happens every time? The patient coughs, spewing virus in their face, but they do it anyway. When two patients need one machine, they put them both on the machine. Something that's never been done, a ventilator shared by two people. That is the heroic side. That is the positive side of that physician culture. In the book Uncaring, How the Culture of Medicine Kills Doctors and Patients, I have dozens of examples of the problems. But I thought today we'd talk about 3 of them. The first one is in the culture of medicine. Prevention, better management of chronic disease is just not valued. We elevate the physician who unblocks the coronary artery. We ignore the people who prevent it from occluding in the first place. In New York City, 88% of the people who died had 2 or more chronic diseases. The most common disease was hypertension. Across the United States today, we manage hypertension effectively 55 to 60% of the time. When I was the CEO in Kaiser Permanente, we did it over 90%. We had excellent doctors, so did the community. We had great medicines, so did the community. What's the difference? It's a culture that values prevention and values the role of primary care at being able not just to take care of a problem, but prevent it. I mean, ask yourself, if you were going to create a hierarchy, what specialty would you put at the top? How would you do it objectively? You'd look at who saves the most lives. Well, Harvard and Stanford both looked at this question. Adding 10 primary care physicians to a community increases longevity 2.5 times more than adding 10 specialists. But who's at the top of the hierarchy? It should be primary care. But it's not. It's a specialty that intervenes. It's this culture of medicine that values the wrong things that is contributing to the problems of American healthcare today as strongly as the broken system that exists. The second area is telemedicine. 7 years ago, I wrote an article for Health Affairs, and I pointed out that at the time we were doing 10 million virtual visits a year. And I predicted that within a few years, 30–40% of what we do in the medical office would get replaced by a telemedicine visit. And I waited. And I waited, and nothing changed. We were still in the low single digits. And then COVID comes. Doctors have to close their office, and all of a sudden it soars. 60–70% of some practices become virtual. But what happens today? We're back down around 10%, more than in the past, but nowhere near what's possible. Now, go back and read the literature. There were no quality problems. Telemedicine is immediate care rather than delayed care. It's better for the patient, more convenient, it should be lower cost. Why are we not doing 30 or 40% of the care virtually? And it's the same culture of medicine. Because in the culture of medicine, what elevates someone? It's the office. The name is on the front door. All the staff are very differential. You walk through the front door, what's that? A waiting. Your job is to wait for the clinician's time, which is far more important. And telemedicine eliminates that. The opportunity for the culture to change would allow us to provide care that was quicker, higher quality, low cost. The third part I want to talk about is burnout. Surveys have been done about the causes of burnout, and clinicians say the same thing. 3 causes. We don't get paid enough, so we have to see too many patients a day. The bureaucratic tasks are really problematic, particularly prior authorization, and the computer system comes between us and our patients, literally. And all 3 are accurate. They all need to change and improve. But if you look at the data, and I followed very closely from Medscape, what you see is that although the average is 44%, there's a tremendous spread between the most burned out and least burned out specialties. And there's some surprises. At least prior to COVID, the most burned out specialty was urology. Now think about that. Urology, they make $500,000 a year. So it can't be money that is the sole driver. And orthopedics and ophthalmology, that is about half the burnout rate, they have to do the same bureaucratic tasks in the computers. So why should urology be the most burned out specialty? And the answer goes back to 2010. 2010, what do we see? Urology is one of the least burned out specialties. The National Preventive Task Force says that the PSA test no longer adds much value. And the number of patients diagnosed with prostate cancer and getting robotic prostatectomy starts to drop. And then a few years later, what we find is that watchful waiting is as good as intervention without the risks of the impotence and urinary incontinence, and it drops again. And then finally, patients figure out that on the internet, they can figure out which surgeons have done the most cases, and that's who you want operating on you, given the risks associated with the procedure. Now, why should this one operation, because that's the only thing that changes, take urology from the bottom of the burnout rate to the top of the burnout rate? Not logical. It's culture. Because in the culture of medicine, what gets you to the top? If you do the most cutting-edge interventions, the coolest procedure, and there is nothing cooler than doing a robotic prostatectomy. It is video games on steroids. You sit there and you move 8 arms at a time, and it all happens, and you command that operative field in a way you can't even do it if you have the hands on the patient themselves. Sir Michael Marmot, who's a sociologist from England, has pointed out that losing status creates unfulfillment, lack of satisfaction, fatigue, the classic symptoms of burnout. And much of burnout comes from the systemic issues, but some of it comes from the cultural ones. And I think a lot of what's happening in primary care does reflect that today for the physicians not in the room today, because your status has gone up as direct primary care providers, not down. So let's look at some of the changes that need to happen in the role of direct primary care is playing and needs to play. The first thing is, with the severity of and the incidence of chronic disease, the idea of a single doctor working alone is still left over from the last century. It does not work today. What works today are physicians collaborating and working together, and many of you in the groups that you're in have created exactly that system of working with colleagues, sharing the workload, working with teams of individuals to provide better care. But I think you can do even better. I was in New York last week. I was speaking to some CEOs, and I asked them the following questions. It's 10 o'clock at night. Your 4-year-old has 102.5 fever. Who do you call? And these are the CEOs of big companies. Coverage is not an issue. Money's not an issue. You know their answer? No one. There's no one to call in New York City between 10 p.m. and 6 a.m. to get the kind of care that you need. Your only choice is going to the ER or taking your risk at home. But imagine if 21 primary care physicians or 28 physicians and nurse practitioners and other individuals came together, each taking one night of coverage. We did this in the Mid-Atlantic. 70% of the problems could be solved that night. The kid's lying there, listless. You say, race to the ER. I'm going to call the doc and warn him meningitis may be coming in. Kids riding the bike around, smiling. You say, go back to sleep. I'll book you an appointment with your physician tomorrow morning. That is the power of video when done by a group of individuals. How about the move from fee-for-service to capitation? That's direct primary care. Because capitation aligns the incentives. It raises prevention's importance. It means using technology that provides care. It means working together in teams. All of the right things happen. But again, I'll push you. Because capitation only in primary care is a piece of the problem. Why not bring specialists in who can help provide that care so that you can take a bigger cap, a larger piece of the pie, and reduce costs even more, saving the dollars that can now be invested in the care delivery and in the income of the physicians collaborating and working in a different way going forward. Third opportunity is modern technology, and I'm talking particularly about telemedicine. As I said, telemedicine is often, about 40% of the time, better than an in-person visit. But so much more can be done. I wrote a piece in Harvard Business Review in May where I talk about applications that we had done. Let me give you an example. You can have a specialist available to support a large number of primary care physicians, 50 to 100, depends upon the particular problem, and available to come into your exam room virtually while you're seeing a patient. How much better care could you provide if you could have that expertise immediately? We did that in dermatology as an example. Now, you take care of rashes, 90% of them you know exactly what to do. But every once in a while, 10% of the time, the problem is less clear. What do? You tell the patient, go make an appointment in dermatology. That's 6 days, 6 weeks, or 6 months. What do? We had the physician take a picture, or actually the staff take a picture of the rash. We had a dermatologist available to look at it. And we were able to make a diagnosis accurately in 70% of cases within 6 minutes. The patient went home on treatment, getting better. That is better care than we provide today. And we provided this expertise, the specialty expertise to primary care. 40% of the consults could be addressed in the primary care physician's office. Requires a capitated system, because you can't just do that. Specialists won't want to do it if they're not in a fee-for-service world, and you can't overload primary care, but the combination of the team able to accomplish that provides the patient with superior clinical outcomes. And finally, leadership. And I know some of you are in small primary care offices, and many of you are in large groups as large as 100. But as you get to the larger size, there is a structure. There is someone who's able to make change happen. And that is leadership. But I'll push you again, because leadership is not an innate skill. It's a learned skill. And we have to do a better job of training the next generation of leaders. Now, let me emphasize, this change, although it will be far better for patients, and I believe far better for physicians and other clinicians, that it will reduce burnout and provide more fulfillment and joy, because you actually can solve patients' problems, won't be embraced by everyone. There'll be a sense of loss. And Kubler-Ross has talked about the 5 stages of loss, the 5 stages of grief that happen. And we're seeing it. Not the physicians in this room, the ones not in the room. Many are in denial. We don't have to change. The care we provide is great. What are you talking about? Just pay us more money. Then you have people who are basically saying, don't you understand? We're the victims. And in bold capitals and exclamation points, they're angry. But nothing changes. And so they move on to bargaining. We see that with over half of doctors selling their practices to hospitals or to insurance companies. They think it's going to get better. It's not going to get better. They just traded one master for another. It's not going to align as groups like yours with physician leadership that are going to be the key to address the problems for both the patient and the clinician. Then they go to depression. I think a lot of burnout today is depression. I think people are just dissatisfied and they don't see a route out. Not in this room again. You figured out that direct primary care is a great first step towards the goal that needs to be achieved. But ultimately, you get to acceptance. It may not be how you want to design the system. You might like to change the insurance companies and the hospitals and everything else. But you start to accept this is the reality, and what can we do? What are the choices we can make that will be that much better? And once you get there, I think 3 things happen. Number 1, you redefine autonomy. Autonomy, mastery, and purpose are the 3 things that we know from the literature maximize anyone's job satisfaction, but particularly someone in healthcare. Autonomy is not every doctor doing what he or she thinks best and wants to do. It's groups of physicians like yourself coming together, looking at the literature, and figuring out the evidence-best way for us to provide care. Once the physicians can all agree on that pathway, then everyone does it. It's not the variation, it's the agreement. Now, there's some places we can't agree and we have to study it. But where we can, then we can be certain that everyone, whoever's helping to cover our patients tonight or this weekend or whatever it may be, is going to provide the same care that I would provide, because it's what the literature says is the right way to go, and when the evidence changes, so will our practice. And mastery. Mastery in American medicine today is specialty focused, but mastery is going to be teams of individuals putting care to patients that is better. It's not the specialist above primary care. It's not the primary care in isolation. It's working together for the overall benefit of the patient. That is the mastery. It's raising quality 30% and making care more convenient at lower cost. And it's doable through the work that you've already started and the steps that can still happen. And finally, you get to purpose. The purpose in medicine isn't curing disease. It's keeping people healthy. It's promoting wellness. It is all the things that we went into medicine many years ago to do and has somehow gotten lost in a broken system and a problematic culture. And I'm convinced that together, if we all can lead the way, we can once again make American medicine the best in the world, and the direct primary care individuals in this room and across this nation, we're the ones to lead and show the way. I thank you in advance for your great work.